Hey there everyone, this is Dr. Suchard again with a video presentation on Principles of Antidote Stocking, which corresponds to Goldfrank's chapter SC1. This video is going to be on the shorter side, and there's only one learning objective, namely, to be able to explain at least two reasons why it might be difficult to create and maintain a well-stocked antidote pharmacy, which to me appears to be the major point of the textbook chapter. You might know all about a whole range of antidotes and how they work, but where the rubber hits the road, as it were, somebody has to order, inventory, maintain, and dispense those medications, and that's not as easy of a job as it might first appear. There are any number of published antidote stocking guidelines out there, including this example from the Annals of Emergency Medicine, Expert Consensus Guidelines for Stocking of Antidotes in Hospitals that Provide Emergency Care from 2018. A large and varied group of experts looked at all the data and came up with a list of 44 recommended antidotes, of which 23 should be immediately available, and another 14 should be available within 1 hour. So that's a pretty big list, especially since some of those antidotes won't be given very often. If we take a closer look at just the first 16 antidotes listed alphabetically, because that's how many conveniently fit on a single slide, we see here a wide range of clinical indications and can make some comments about their relative frequency. First up is acetylcysteine, which is a very commonly used antidote for acetaminophen toxicity, and I think that anyone working in an acute care hospital is going to see it used many times. But next up are antivenoms for black widow spider and coral snake envenomation, which are very rarely used, and most clinicians will go their entire career and never order or administer these antidotes. Here we see some additional consensus guidelines where the authors indicate the strength of the available evidence and whether the antidote should be stocked in hospitals that provide emergency care. It looks like the authors never saw an antidote they didn't like, since they recommended stocking virtually every antidote they reviewed. However, they did agree that not all antidotes needed to be immediately available, say in the emergency department, but this still leaves the issues of stocking and maintaining them in some centralized pharmacy and being able to dispense them relatively urgently when needed. The textbook chapter spends a lot of its length looking through several pharmacy availability studies that appear to show inadequate antidote stocking. To me, these studies fall into a category that is fairly common across all aspects of clinical medicine, where the investigators are looking at some ideal condition within healthcare that we'd like to aspire to, and then finds that we aren't meeting that ideal, which to me is not surprising. Congratulations, you've just proven what we should have suspected all along, i.e., that nobody's perfect. If antidote stocking is not meeting these ideals, sure, that's disheartening, but does this translate into excess morbidity and mortality from poisoning? I suppose that's possible, but these studies only suggest that possibility without providing any good evidence for it. Much of the remainder of this chapter looks at various factors that can make antidote stocking more difficult. First off, as already mentioned, some antidotes are only infrequently used. It's very easy to justify stocking drugs that you use all the time, but those used more rarely may be more difficult to find and/or have higher price markups, making initial stocking more costly. And if the drugs are used so infrequently that they expire on the shelf, you'll need to replace them, potentially increasing costs further in the absence of any patients getting clinical benefit. The antidotes most needed can vary from location to location, depending on things like the leading industries and agriculture in the area and the range of toxic flora and fauna. Also, there are potential problems with drug shortages. While shortages can obviously occur with any class of drugs, antidote shortages are overrepresented, likely because commercial demand is relatively low. And while if a given antibiotic or blood pressure medicine is in short supply, there's almost always another agent available. With antidotes, it's much more likely that there are no viable alternatives. Local medical practice can also affect which antidotes will need to be stocked. For instance, there's a whole range of agents, as listed here, used to treat toxicity from drugs used in oncology. So if you're working at a designated cancer center, such as exists at UC Irvine, you'll need to pay closer attention to stocking these agents than you would at, say, a more general acute care facility. And then finally, the chapter includes its own list of antidotes and stocking recommendations, which you are free to peruse on your own, but these kind of details really aren't important for us right now. I'll be seeing you around.